I'm Dr. Victoria, and this is George.
I'm Dr. Victoria, and today I am joined once again by George's twin, Georgiana. Georgiana is here to join us as we talk about what she will experience during her second trimester office visits. She will have office visits every 4 weeks up until 28 weeks unless there's a reason to be seen more frequently. At each visit, as part of our exam, we'll measure fundal height and use a Doppler to look for heart tones for baby. We expect that the fundal height in centimeters should correspond to her weeks of gestation, but this can vary depending on body habitus. We'll weigh mom as well to make sure she's having appropriate weight gain. Georgiana will have some physical changes she'll notice. The nausea that she experienced during the first trimester should be starting to calm down before it starts up again in the third trimester. She may notice some round ligament pain. This is at the lateral and lower abdomen. The ligaments supporting the uterus are stretching, and we recommend for the pain rest and warm compresses or heating pads. But really, the discomfort is really worse in the first and third trimester. She'll likely start noticing some changes in her breasts as well. They can get larger, firmer, and more tender. The areolas start to get darker, and since she can start making colostrum halfway through the pregnancy, usually about 16 weeks, she can notice that her breasts are leaking. Acid reflux can start to get worse. We recommend starting slowly when it comes to medication and working our way up, starting with something like Tums, then a histamine 2 antagonist like famotidine, and then if those modalities don't work, our proton pump inhibitors like omeprazole. As well, some lifestyle interventions, including avoiding caffeine, carbonation, spicy foods, and not lying down after eating can also be helpful. There are several tests that we do during the third trimester. At weeks 24 to 28, we'll check for gestational diabetes. Initially, we do a 50-gram, 1-hour glucose test. Patients can take the glucose orally. We usually have several flavors that the patient can choose from. At the visit before their test, they can take this drink home with them with instructions on how to drink the sugary drink. The patient can drink the beverage just before she comes to her next appointment. We'll want to get the patient to write down the time they drink the beverage. We want to time our test 1 hour from when the patient drinks the glucose solution. Measuring should be quite accurate and occur precisely 1 hour later. If the glucose is greater than 135 to 140 milligrams per deciliter, that is a positive initial screening test. If it is a positive test, we'll follow this up with a 3-hour glucose test using 100 grams of glucose orally. But really, it's more like a 4-hour test for the patient, and patients need to be monitored the whole time. Tell them to pack some entertainment because they'll be at the clinic for a while they wait to have their glucose measured every hour. There needs to be 2 elevated glucose readings for a positive test. When doing both of these glucose tolerance tests, the entire glucose solution should be ingested within 5 minutes, and patients cannot eat or drink during the duration of the test. Genetic screening will also occur during this time. At weeks 15 to 22, we can screen for trisomy 21. This is usually done via a quadruple test measuring serum alpha-fetoprotein, unconjugated estradiol, free beta-HCG, and inhibin A. Alternatively, there is cell-free DNA testing available starting in the first trimester, and gold standard testing is chorionic villus sampling between weeks 10 to 13 and amniocentesis in the second trimester with fetal karyotyping. But with these later tests, there is a risk of fetal loss with these procedures. At weeks 18 to 22, we can screen for structural anomalies like renal defect. Many anomalies can be seen in the first trimester, but ultrasound examinations are more sensitive in the second trimester. At weeks 16 to 24, ultrasound can also diagnose cervical insufficiency. If there is a cervical length less than 25 millimeters, there can be an increased risk of second trimester pregnancy loss and preterm births. But treatment with vaginal progesterone can be of use to reduce this rate. At weeks 24 to 28, we'll check the hemoglobin and hematocrit to monitor for anemia, and we'll continue to monitor blood pressure. Blood pressure is usually lower during the first trimester and then creeps up again during the second trimester if it's going to be elevated. It's always helpful to know if our patient has elevated blood pressure before her pregnancy. It does make a difference if it's essential hypertension or gestational hypertension, as gestational hypertension can get our hackles up since it can lead to preeclampsia, eclampsia, and even HELLP syndrome. If her Rh immunoglobulin test was negative during her first visit, we test again during weeks 24 to 28, usually week 28. We'll also screen for anti-D antibodies in Rh-negative women and for fetal anemia because of alloimmunization. Anti-D antibodies occur when mom is Rh negative, but baby now or in a previous pregnancy was Rh positive, so the dad would have had to have been Rh positive. We do an indirect Coombs test to check for anti-D antibodies. If it is negative, mom doesn't have any antibodies. If it is positive, that means mom is alloimmunized and has made anti-D antibodies and baby is at risk of red blood cell attack and anemia. If mom is Rh negative and the indirect Coombs test is negative, we want to give some RhoGAM. That's just 300 milligrams of anti-D immunoglobulin at weeks 26 to 30 weeks of gestation, as well as within 72 hours of delivery. RhoGAM is also given at other times when the patient could be exposed to a disruption of the placenta or fetal-maternal interface, including spontaneous or induced abortion, invasive diagnostic or therapeutic procedures like chorionic villus sampling or amniocentesis, trauma, or an ectopic pregnancy. If mom has been sensitized, you can monitor for fetal hemolysis with serial ultrasound and middle cerebral artery Doppler vacillometry. If there is severe hemolysis, you can do intrauterine blood transfusion via the umbilical vein, or sometimes preterm delivery is indicated. Some anticipatory guidance we want to give Georgiana can include encouraging her to find a pediatrician for her new baby, pre-registering at the local hospital if necessary, and attending classes on childbirth and lactation. We'll want to encourage her to continue to take prenatal vitamins that she'll want to continue to take even past delivery into the season of breastfeeding. As well, Georgiana can be reminded of some signs and symptoms to report right away if they occur: vaginal bleeding, leakage of fluid per vagina, decreased fetal activity. Mom can start to feel baby moving at 18 to 20 weeks, but this isn't consistent until 28 weeks. And this is body habitus dependent. Signs and symptoms of preterm labor include low backache, increased uterine activity, menstrual-like cramps, diarrhea, increased pelvic pressure, leakage of clear fluid, spotting or bleeding, and contractions. As well, signs and symptoms of preeclampsia include headache that doesn't respond to one dose of Tylenol, visual changes, and persistent epigastric or right upper quadrant abdominal pain. Thank you for joining me today, my healthcare team. It is so exciting to care for new moms and their bundles of joy about to enter the world. I hope you'll join us next time. Bye-bye. Way to go, Georgiana!
You can move it down if you need to, like type of thing without getting like, PG-13 for YouTube.